So I'm going to talk about healthcare costs in retirement. And I thought I would start at a slightly different place because in this presentation will get a little morbid, as I go on. So I thought, I will start at a slightly, better place. So when we think about healthcare costs, the general image that we have in mind is that of a concern, right? That, it's a negative image. But what I found is rarely discussed, in this discussion is how satisfied people are. So this is a question from 2022 HRS, which is a pretty broad question. As you can see, I have the actual question written there. So considering quality, cost and convenience, people are actually very highly satisfied with healthcare. Right. So this is something, I think we should keep in mind when we have having the discussion. Now moving on to the actual, costs. So it turns out, this is a really important issue, and there is a lot of research on this. So it's not that I'm going to be, telling you something, really new. But, I hope that there are some unique aspects that I'll share today. But what I have done here is I have somewhat arbitrarily divided the literature into three categories. So the first one, which I call are the papers that look at the empirical, trends and establish sort of the facts. And my paper, squarely fits into this group. And then there is another group of papers which tries to understand the dynamics of healthcare costs and tries to model them. And then finally, there is another set of papers which try to estimate the cumulative costs of healthcare in retirement. So if you look at sort of the first set of groups, there are some very well-established facts. First of all, expenses. There's a huge age component to it, so it rises pretty fast with age. And then it's pretty much a tail risk that sort of a very few minority, they account for most of the costs, healthcare costs. And then finally, there is sort of a spike or big increase in healthcare costs at the end of life. And I'll share some numbers on, I think, all of them. So in the modeling papers, I think it generally establishes that healthcare cost follows like a time series model with one lag and a white noise component to it. And then finally, there are all these, this is, the cumulative literature is probably the ones that's most covered by the press, because press really likes those big numbers. I'm sure many of you have seen something in the press that, a 65-year-old will need, whatever, $300,000, $400,000. Personally, I don't like that framing that much. There are a couple of reasons for that. So one, I think without the additional knowledge of, showing your income and investments in the same present discounted form, it is kind of hard to judge the relative magnitude of these, of these numbers. And the other one is that healthcare is really not a lump sum decision, these expenses. So it's not that you retire, you pay someone, whatever, $300,000, $400,000. It's still a series of decisions that you have to make every year. So knowing that number, that one number, it's not really helpful from a planning perspective. Okay, so now the data, and I think HRS has been described many, many times here in the last 2 days, so I will not go there. Everyone knows HRS, so I'm sticking with Medicare recipients who are 65 and above. And the only thing that I really want to point out, it could be seen as a limitation, is that I exclude people covered by Medicaid. And the reason for that is I just wanted to see the full extent of these costs, right? So keep that in mind, particularly when we look at the nursing home expenses and all that. Just have to keep that in mind because Medicaid is a big factor there. So these numbers, at least the nursing home numbers and costs, are not fully representative because it's the non-Medicaid population. I use the HRS core sample from 2020 for most of the paper, and then to look at the end of life, I use what is called the exit sample. It's the people in the HRS panel who have passed away, and there's a final interview with one of their close family members, usually a spouse or a surviving spouse or a child. And yeah, so we use the health insurance premiums as reported by the participants, and I do take the Medicare premiums from the published tables. And yeah, so those are the components, as you can see, that's included in this. So what do these look like? So here is sort of a visual representation, and I break it out by premiums, out-of-pocket, and total expenses. So the first thing visually, which is apparent, that it has a sort of, it's skewed towards the top end. Again, this is pretty well established in the literature. You can see that the distribution is not symmetric. If you look at the whiskers, the one at the top is much higher. The other interesting thing here is that you will see that there is quite a bit of distribution mass that lies outside the whiskers, or sort of in the outlier zone. For the out-of-pocket costs, I think that's just the nature of healthcare, because some people, they spend more on, they have healthcare needs, and they end up spending more. On the premium side, it has probably something to do with the income distribution, because as you know, there are some additional premiums people have to pay that based on their income. It's the income-related monthly adjustment amounts, or ARMA. So that's probably causing sort of the extended tail on the premiums. So here are some of the actual numbers. And this is sort of one of the unique aspects of our work, is that we break it out by three common types of coverage. So on the left, you have traditional Medicare with a drug coverage, Part D. In the middle, you have Medicare Advantage, or the HMO plans. And finally, on the right, you have traditional Medicare combined with the Medigap. And we're showing the numbers for median, the 90th percentile, and the 95th percentile. So as you can see from the total expenses, so traditional Medicare and Medicare Advantage, the costs are pretty much the same. There's not much of a difference. But with Medigap, of course, the total costs are higher, and that's mainly because of the premiums. But one thing you'll notice is that the reason people tend to get Medigap is to limit their out-of-pocket costs. But the out-of-pocket cost under Medigap is not really that different, at least at the median. Then if you go towards the top end, that's where you see that the people with Medigap, they tend to have lower out-of-pocket costs. And I mean, the total expenses are still much higher. And this is something I think it is established in the literature as well. So there are some papers who have looked into this, and they established that people with Medigap, overall they spend more. And there are two possible explanations for this. One is people who get Medigap are, to begin with, they are in worse health. So they expect more care, so they get Medigap. And the other one is kind of a moral hazard argument, which is because they have Medigap, they just use more care because they know they have those limits. And that's sort of the explanation that the literature, the one paper that I mentioned here, that they sort of point towards. It's more consistent with that moral hazard kind of behavior. So then I look at conditions. So basically, what's the incidence of different conditions, and what are the costs associated with it? So you can see here just the incidence of all the different conditions. The one that I would like to point out is what's called psychiatric problems. So this is actually a pretty a broad question. So it includes psychiatric, emotional, and nervous issues. And under that, it actually covers Alzheimer's and dementia-related conditions. So when you see the next slide, I just want to keep that in mind. What I really wanted to look at the univariate distributions for all these conditions, but then I soon realized it's not really useful to look at the univariate distributions for each condition, mainly because people have more than one condition, right? And I have an example in the paper where I looked at sort of a Venn diagram of 3 of the common conditions, I think diabetes, heart condition, and high blood pressure. And so 80% of the sample had at least one of those 3 conditions, and 9% of the sample had all 3 of them, right? So it's just not possible to look at the univariate distributions. So what I ended up doing is what any economist would do. I ran a regression. And so here you can see sort of the percentage increase that is associated with each of these conditions. So I have a bunch of demographic controls, age, gender, assets, and so on. So what you see here, all these conditions except for arthritis has a statistically significant effect on out-of-pocket expenses. And the one that shows up with the highest impact is heart conditions at 55%. So there's annual out-of-pocket costs increased by 55%. And then psychiatric problems and lung disease is sort of the next 2. And you can see sort of the impact of the rest of the conditions. Okay, so this is the final section of the paper, which is looking at the end of life. So this is where I use the data from the exit sample. So the first slide here, it's just asking the question: is there a noticeable spike in expenses at the end of life? And we're looking only at out-of-pocket expenses. And I think the answer is pretty obvious that there is a spike. So the dark blue bars are the ones for people who are alive in that age group, and the light blue bars are sort of people who passed away at that age, right? So if you look on the left, the chart on the left-hand side, that's the median, and you can see what the differences are at the median level. And then if you look at the 95th percentile at the higher end, the differences are much, much higher. So it is kind of clear that there is a noticeable increase at the end. Then I look at sort of the nursing home piece of it. So the first chart here, it's just looking at the entry rates, the incidence of people entering a nursing home. Again, here the dark blue bars are those who had a nursing home entry in sort of the last 1 to 2 years of their life. As you can see, once past the age of 80, majority has at least an entry into a nursing home. And keep in mind here that this is the non-Medicaid population, so the actual number might be a little higher, right? And then I'm looking at the frequency of their stays. So about roughly 50% in this sample, they did not have an entry. And then you can see another 15% or so, their stay was less than a month. And on the top higher end, about 8.7% had stays longer than 2 years, right? And then on the average stay, and this is conditional, so this is conditional on entry into a nursing home. The average stay is about 145 nights. And you can see there's a clear trend with age as it goes up with age. Okay. And finally, the expenses, the annualized cost. So this is what they spent on out-of-pocket expense in the final year of their life. So again, I'm showing the 50th percentile, 90th, and 95th percentile. There is again, a strong age component, and you can see at the higher end, people who are, if they're living up to 90 plus and they're unfortunate, to be in that 95th percentile, even in that one single year, the expenses could be really, really high. But again, the probability of that is pretty low because we're looking at someone living past 90 and then being in that 90th or 95th percentile of that, of that age group, right? But it's a tail risk. So, and a lot of that is really coming from nursing home long-term care, right? So this is just looking at the same group, but how much of the out-of-pocket expenses came from nursing home. The good news here is at the median, it's still 0. Doesn't matter what the age is, but it's really at the higher end, the 90th and the 95th percentile, where you see the really large numbers. Okay. Very quickly, I was asked to, the paper should cover a little bit of, how to plan for these. And I think there are, again, 3 buckets that I think of when thinking about preparing for these. One is, choosing the right coverage. There are tons of variation within Medicare, the different types of coverage, there are different plans. Some plans people could change annually, so it's just making sure that they have the right coverage for their personal situation. And the second one is saving and investing. The key component there, at least from the investing perspective, is the use of HSAs. So we know that's sort of the best investment vehicle that's out there. If it's used properly, people never have to pay any taxes on that. So that is kind of very unique. Hopefully people are using that properly. And the final one is how to ensure that end of life tail risk. Usually for this kind of situation, we would recommend insurance coverage, but the private long-term care insurance, it hasn't been successful. So I think there is some focus on the public coverage. And the last thing I want to leave with is that there are some innovations or things happening on public coverage of long-term care insurance. So on last November election night, I think everyone was focused on the big election outcome, but there was a small ballot measure in the state of Washington. So the Washington had, in 2023, started a mandatory payroll-funded long-term care insurance program. And it was on the ballot that people, whether people wanted to opt out of that program or not, and that ballot measure was defeated, so that the program is alive. So this is probably one testing ground that what happens to see whether other states pick up that and where we go from there. Thank you.